Okay, so many of you have shown great interest in this January 2026 paper. So let's solve them together and we will do one module at a time, right? Now we will do general gynecology module, this paper recalls, right? So let's begin with the general gynecology. Feel free to answer each question in comments before checking the explanation. And let's learn together and strengthen our exam approach. So, question number one, 34-year-old patient, and she's having symptomatic endometriosis. She's on linzagolix as a part of her medical management. So they are asking its mechanism of action. Linzagolix is a routine, drug which gynecologists used to prescribe every day in their OPDs. So this is GnRH antagonist. Uh, Remember this trade name. In this paper, they have asked twice about this drug. Okay, so it's very simple, basic. Moving on, second question, 34-year-old patient. She's again having long-term treatment, but she is taking GnRH analog for her endometriosis. And duration of treatment is more than 6 months, which is 7 years. And they're asking about the DEXA scan frequency. So this is a repeat question. They have multiple tested this question in previous paper as well. So let's revise some rules. So yes, keys, by the way, see, they said do DEXA annually while she is, taking the treatment. Why? Because this GnRH analog side effect is hypoestrogenism. And look at her age, only 34. And check the time, long time, right? 7 months. And if patient is using any hypoestrogenic treatment more than 6 months, her bones will be weak and we have to keep an eye. So NHS says if a patient is high risk for osteoporosis, DEXA we should start before starting the treatment as well if she is having already established risk factors, right? And however, if the drugs who cause hypoestrogenism, then DEXA should be done after the first year of treatment. Beyond 1 year, further DEXA as clinically indicated. Its frequency determined by the specialist, right? According to the changings which they will see on that annual DEXA. So for the memory hook, remember, if patient is using GnRH over 6 months, then you have to do annual DEXA scanning. And if patient is having menopausal symptoms or when indicated, then you have to do it 2 yearly. If a patient is having premature ovarian failure and her evaluation test, which we do at the time of diagnosis, is normal, then we will repeat only if new risk factors added, right? And at the time of the premature ovarian failure, if she is having abnormal DEXA, then this is important. Then you have to keep an eye, and you have to do her screening 3 to 4 yearly with HRT. She must take HRT with this ovarian failure, premature ovarian failure reason. So this is all about DEXA screening. So coming towards the question. Okay, so they said she is having actually a minute. Yes, she is having long-term GnRH, and but the GnRH will cause it will reduce the estrogen, and reduced estrogen will weaken the bones and take the time as well. And she's already taking advac therapy. That is a good thing. But even then, she need annual screening, right? So option C is ideal and available as well. Okay. So question number 3. I will be quick in this paper because you people have revised these all things recently, and many of the reference you already know. So we will not actually give additional time to do the things which we have already covered. Question number 3, 27-year-old patient presents with severe pain and swelling of the left labia majora. For 3 days, she has fever, difficult sitting. Examination reveals 3 centimeter fluctuant tender swelling, and basically it's a abscess. So at 27 year and at this location of the vulva at left of the majora, we know this is the classical site for Bartholin abscess. And for any abscess, the primary treatment is you have to drain it. Alone antibiotics won't add any, great benefit. So ideal will be you go for incision and drainage, and then you will add supportive treatment, which will be the antibiotics. So only if we will pick option A, then it will not be a very smart choice, right? And our buzz is appropriate. So primary treatment we have to pick. So primary treatment is incision drainage. We already know. Now we will read the choices, and I think the option B is perfect here. Incision and drainage under local anesthesia. Okay. So question number, yes. Painful fluctuant vulval abscess require drainage. Antibiotics alone are insufficient unless there is extensive cellulitis or systemic abscess. Okay. Systemic sepsis because of any reason, because of sepsis or any other thing, then you have to follow the sepsis 6. And in this, the antibiotics or broad spectrum antibiotics are, comes in top 6. So then it will be the exceptional situation. Question number 4. 56-year-old patient presents to the emergency department with acute pleuritic chest pain, and she's taking HRT. Look at her BP, and her saturation is dropping, and she's tachycardic, and CTP confirms that it is pulmonary embolism. So what is the most appropriate management regarding her HRT? If patient is taking HRT, HRT in itself is a thrombogenic, and VT comes in its immediate side effects, which we observe in 4 months after start of this treatment. So you have to stop it, right? So you can't continue. You have to stop immediately and start anticoagulation. This is the perfect option. Switch to transdermal HRT and then start anticoagulation. No, it's not correct. We can switch her to transdermal route, but we will not wait. Like, this is not a life-threatening condition if we actually give the priority to switching on transdermal HRT, and after this we will start anticoagulation. So this sequence is not wise, but maybe later when she will be stable, we may start to think about to put her on transdermal HRT, because a patient who is having personal history of VT can take HRT, but we will change the route. But right now she need immediate anticoagulation. So we will stop it and we will start. So B is ideal. C is actually not a safe option. So moving, I'm giving you some slides which you have seen a lot of time, an indication to use transdermal, and you can see that a patient who's having personal preference and like obesity, smoking, and VT, right? CVT. So if the same patient later after her recovery, she want to start HRT, we will give her transdermal HRT. Okay. Okay, so question number 5. ST elevation. ST elevation, like she's having MI. If patient is having MI again, we will not, and she's taking combined HRT for 1 year at this age 56 year. So same classical principle, we have to stop HRT, right? And we have to manage her MI, and later in her life, like in future, if she want HRT again, then we may discuss with her, and under consultant-led care, we can change the route. Okay. So currently the safe choice is option B. Okay. So they said stop HRT immediately, continue HRT and start standard MI treatment, switch to transdermal HRT, reduce the dose of HRT, restart HRT after discharge. So the ideal will be that we have to start immediately the standard MI management, and we have to stop HRT as well. So option A is partially okay. That's why like with this option continuation, we can't choose it. You may think like she needs standard MI treatment, but you are assuming that they said don't give standard MI treatment. They just said stop HRT. Maybe this is half information, but with half information, no wrong choice. And here, this is the ideal treatment, But with this ideal treatment, this is wrong option. So, like half truth, half lies. Don't opt it. So the stop HRT will be the safe choice. And obviously, they have not added here, don't give her MI treatment. You are assuming yourself. Many at student level, we assume that they are saying don't give her MI treatment, where they have written no. So B is okay, part of management, right? And after this, we will start standard, MI treatment. Okay. Okay. And ideal will be that immediately we have to start MI treatment on this, clinical findings and with this ECG, and we have to stop HRT. Okay. So these are recalls. Maybe in real exam, you will find a better wise option. So see, cautious use or contraindication, breast cancer with HRT, endometrial cancer, active liver disease, previous VT, high cardiovascular risk, unexplained vaginal bleeding. This is a menopausal guideline which they have published in 2026, and a lot of articles released before this guideline as well. So question number 6, low FSH, low LH, and low estradiol. This is, perfect classical triangle of Kalman, hypogonadotrophic hypogonadism. Everything is low. If FSH will be high with low estradiol, then it can be premature ovarian and failure or Turner syndrome. Okay. Question number 7, menopausal symptoms. Now, now you can notice they are after menopause. Consecutively, you will see 4 to 5 questions on HRT and menopause. Okay, so 52 menopausal symptoms, taking Monjaro for diabetes, type 2 diabetes, and she requests HRT. She has intact uterus. Which of the following is the most appropriate progestogen option for her? They are not asking about the type of HRT. They are asking about the type of progestogens with intact uterus. And she is taking Monjaro. Monjaro cause, Ozempics, what they do? They cause, GIT upset. So any oral root-based drug will not be good in that case. So progestogen we will give her, which will be absorbed locally, like Marina. So without actually looking at the choices, you can shortlist your ideal key. And if you have shortlisted your ideal key, and after this you are reading the question, then you easily pick non-biased key. Okay, so I'm hopeful we will find Marina. See, we can find Marina here. Okay. Question number 8. 42-year-old patient presents with heavy menstrual bleeding due to the fibroids, and she started on linzagolix. I told you in this question they asked about this drug 2 times, and this is the second time. And they are again asking about its mechanism of action. And we know that this is antagonist, means competitive antagonism of GnRH receptors. This is the ideal key and available as well. Okay, question number 9. 52-year-old patient with symptomatic fibroids is planned for hysterectomy. During the teaching session on sustainable healthcare, the consultant discussed the environmental impact of different surgical approach, which type of hysterectomy is associated with the highest carbon footprint. They love actually carbon footprint. In July, they have asked question which were on nitric oxide gas, and again in January they asked about. So remember, so robotic surgeries generally has the highest environmental burden due to the disposable instruments, energy use, and equipments related resource use. So in robotic surgeries, we will add a lot of waste products in environment, and will be more carbon result of more carbon footprint, which will give to environment. So vaginal hysterectomies are the safest one. They give ultimate minimal access operation and has around 1/4 of environmental impact of laparoscopic hysterectomies. And nitrous oxide in Antonox has a major environmental impact because it persists in an atmosphere for 114 years and has 270 times the global warming potential. They asked this question in July. So highest carbon footprint you will see in robotic assisted laparoscopic cystectomies are procedures. And after this in total laparoscopic, and after this abdominal, and the safest, the lowest one will be in VH. Remember this. Might be they will again ask in your exam. So here is the references. Okay, question number 10. 44-year-old patient present with 1 year of history of irregular, heavy, and unpredictable cycle. Pregnancy test is negative, pelvic ultrasound is normal, medical management she is requesting, and she also wants contraception. Which is the most appropriate treatment? Okay, so basically she is having okay, what contraception we can offer her? Ethinyl estradiol, drospirenone. After 40, OCPs are not safe. So A and B out. Cyclical oral norethistron, POPs are not safe. And tranexamic acid is not OCP as or any contraceptive as well. So after 40 years, long-acting reversible methods are more okay. And she's having heavy cycle as well. So heavy cycle, age more than 40, she need long-acting reversible methods, which we already have, which is Mirena. And they said ultrasound is okay. So we will assume the uterine cavity is normal. Okay. So this is, a little bit easy question. Next is 11, painful oral ulcers, painful vulval ulcers, and red eye. This is a repeat question we discussed in recalls multiple times. How to differentiate lichen sclerosis, lichen planus, and Behçet's. So it's Behçet's, right? Triad, they have completed the triad. Recurrent oral aphthous ulcers, recurrent painful genital ulcers, and oral ocular involvement, uveitis. And I remember one question in recall where there were only dryness in eye with Wickham stria and with oral patches as well. So that was lichen planus. So I have added the differences is with buzzword as well. Remember this. They love it. They have asked this question twice. Earlier, they asked that they have given the question on lichen planus, in which there were eye symptoms, but no red eye. There were only dryness, itching, vulval itching, eye itching on eye, and mucosal involvement, mouth patches, Wickham stria. The everything was classical buzz of lichen planus. But here there are oral ulcers. They are red eyes. The try is perfect. Okay. So question number 12. 28-year-old patient is investigated for recurrent second trimester losses. Imaging reveals congenital uterine anomaly. Which of the following uterine anomalies associated with the highest risk of preterm labor? We know this, and I told you in uterine anomalies as well that didelphys are, actually septate uterus and bicarbonate are associated with more miscarriages. But didelphys is also associated with miscarriages, but the actually percentage of preterm labor is more if it is didelphys uterus, and they particularly ask about the preterm labor. So only option E matches with this. Okay, others do ask preterm labor, but percentages of didelphys is more. You already know this. This is a repeat question. Multiple times they have tested. 16-year-old patient, phenotypically female, means she's having breast. Primary amenorrhea, absent pubic hair, and blind vagina. This is perfect triad for androgen insensitive syndrome. So that was EMQ in your exam, and we are not actually reading the options as well, because we know that's AIS. Primary amenorrhea, blind ending vagina, absent pubic axillary hair. This is classical AIS. However, non-classical AIS, we may see some type of ambiguity as well. But again, I will suggest you do not jump on the key. It would be wise if you are reading the all EMQ options, because in EMQs, like the option O can be AIS with counseling, and it will be better than the only option B, where you will just saying that this is the AIS. So read all choices carefully. You can see the word AIS in 2 or 3 other choices as well. So maybe the option B with counseling will be your key. 15-year-old patient, primary menorrhea, cyclical pain, again, well-developed secondary sexual features, and we can see 14-week size uterus is palpable. And this is a midline pelvic mass because this is hematocolpos. So either it is some, complete atresia, septum, or imperforate hymen. So it's not agenesis, it's not complete AIS, it can be imperforate hymen, and it can be transverse vaginal septum as well. It's not gonadal dysgenesis. So how to exclude transverse vaginal septum or imperforate hymen? Basically, imperforate hymen are common. And second thing is that transverse vaginal septums can be partial. So, and can be complete. But imperforate hymen is, always complete. And see the mass size, midline pelvic mass, 14-week size. So we are suspecting something which is associated with complete obstruction. So in my opinion, the option C is safe. If no option C, then yes, transverse anal septum, if they're complete, patient can, come like that, come with this picture. But when we have ideal key, so it's okay. Another buzzword for imperforate hymen is the bluish, actually, membrane, which is bulging, and you can see at antroitus. And the septum, they look pinkish. Okay, so I am hopeful you will get the difference. You will understand the difference of septum and imperforate hymen. If any, let me know, I'm here. Okay. So this is imperforate hymen, in my opinion. Question number 16. Okay, I'm going a little bit fast because they are the baby questions you have done multiple times. But where you will say me to take a pass, I will take pass and add more details. 36-year-old patient, para 2, presents with secondary menorrhea for 8 months. Her cycles were previously regular, but over the last 2 years, they became increasingly irregular and pregnancy has been excluded. Secondary menorrhea, no pregnancy. This is a type of anovulation. So how we will type anovulation by WHO? WHO says there are 3 types of anovulation. If FSH is low, hypogonadotrophic hypogonadism, normal eugonadotrophic eugonadism, and third means their FSH will be high, hypergonadotrophic hypogonadism. So this is the anovulation based on FSH. So ideal key is already available. 52-year-old patient has history of breast cancer and having, hot flashes. So how to address vasomotor symptoms in breast cancer, whether they are HR positive or negative? The menopause guideline says breast cancer, irrespective of the heart status, is contraindication for hormonal drugs. So how to treat her? If she's taking tamoxifen, we already know we will not give SSRI. And if here they have not mentioned she is on tamoxifen, so the option G, SSRI or SNRI both, or any other non-hormonal, right? We can treat her vasomotor symptoms because no hormones if there is personal history of breast cancer. Okay, so G is ideal. Next is option. Okay, question 18, 48-year-old patient underwent surgery for stage 1C epithelial ovarian cancer, and she has completed treatment and she is disease-free and she has troublesome menopausal symptoms. What is the most appropriate management? Remember my lecture on menopause and HRT. I particularly covered all two articles there, and I particularly shown you that table that epithelial ovarian cancers are safe for HRT. Germ, sex cord, borderline, they are associated with actually insufficient evidence, so better to avoid. But in epithelial, limited data, no evidence that HRT increase recurrence of disease and may be beneficial. Data here again is limited, but they have not said here to avoid. So we can give HRT. Okay. I have added, everything you can read. You can revise basically in how to treat endometrial cancer, cervical, vaginal, vulval cancer if the patient develop vasomotor symptoms, HRT safe or not. Okay. So, but what is the key here? They said option C. estrogen only HRT we can give. Okay, and I have shown you the reference as well. Okay, so what are the options you want to read? No treatment allowed. Why? They said they have not said to avoid it. Non-hormonal, no. Estrogen only, yes. A combined estrogen progesterone, HRT, because see, she has completed the treatment. Once the treatment is THPSO, so why we have to give when there is no uterus, progesterone are not needed. That's why. Estrogen only HRT is ideal because she has taken the treatment of 1C, which is debulking surgery, and debulking surgery means PH&B. So got it? No uterus, no progesterone, so only estrogen. Okay, and HRT says full data is limited, but benefits are there. Okay, question number 19, vulvovaginal dryness, dyspareunia, and recurrent UTI. This is GSM, genitourinary, menopausal syndrome, and she's having breast cancer history as well. In particular, they have added the update in 2024 and 2026 menopause guideline that if patient is having personal history of breast cancer, then even local estrogen is not safe. You will, however, you can give only, under MDD care, means oncological, after oncological review. So stepwise, it would be like that. We will give her non-hormonal lubricants. Okay. So oral combination, no need in GSM. The first line treatment is local in GSM. Transdermal, no need. Tibulone, no need. Continue moisturizers only. Okay, she is not like what type of moisturizers? Okay. Mm, they are failed. Vaginal moisturizers have failed. So she has tried non-hormonal moisturizers, but they failed. So now she need vaginal estrogen, but we can't give now because of this update. And we will, bring her in MDD, and after discussion with the breast oncology team, we can give. So option is perfect, ideal, same, guideline screenshots. And here are the few flashcards. If patient is having CA breast, for vasomotor symptoms, we can give SSRI. And if she is taking atomoxetine, then only SNRI. And COV we can give. See, you already know, we covered all these things. These two questions are from your theory course. And in C endometrium as well, no HRT, only in the further time of 2 years, because like if patient will bleed, we will not actually pinpoint that this is the recurrence of disease or because of hormones effect. And more maximum recurrence we can see in 2 years. That's why we will avoid for the first 2 years. And in DVT we will change the route only. And personal history of breast cancer, we can if you want to give paracetamol or osmipifene, which are newer drugs for vasomotor symptoms, we can give, but not in that patient who is having breast cancer history, neither any local estrogen cream, everything after oncological input. So few flashcards for your revision. Okay, question number 20, 34, 35-year-old patient having endometrioma of 5 centimeter, and her complaint is dyspareunia and pain. And she wishes to conceive within the next year. So endometriosis, here she want to conceive as well, and she is having pain as well. And look at the size. Whether pain or whether infertility concerns at this size, more than 3 centimeter endometrioma will not be suppressed with medical management. Neither medical management is safe in these patients who want to conceive. So we have to do the surgery. Continue combined oral OCPs out, GnRH analogs out, laparoscopic ovarian cystectomy. Fine ultrasound guided aspiration of the cyst, not ultrasound guided, laparoscopic guided aspiration and drainage will be, that can be advised. Expectant out. So C and D, and C is better because we know the first line treatment of endometrioma is cystectomy and laparoscopic ablation and drainage both. And at this big cyst size, The ideal will be if her AMH is less, will be the aspiration and drainage, but via laparoscopy. So they have released a lot of talk article on this, which you already know. Okay. 29-year-old patient, Nelly Perez, and chronic pelvic pain, and despite OCPs and SAIDs, she's having deep endometriosis. What is the most appropriate step? Repeat OCPs, add tranexamic acid, refer to specialist endometriosis, MDTA, perform hysterectomy, bilateral oophorectomy. So we will refer her. And maybe if medical management, they will opt, they can add aromatase inhibitors. Aromatase inhibitors work best in deep endometriosis. And if surgery needed for pelvic pain, we can do surgery, but under specialist care. And for infertility, no need to treat a deep endometriosis at all. You know this. 38-year-old patient. Okay, you want to read it more? Okay. See, if patient comes with endometriosis, we will check her concerns. Her concern is pain or, infertility. If infertility is concerned, or with pain infertility concerned, one thing is for sure, no medical or hormonal treatment, right? So the ideal is laparoscopy. With laparoscopy, we can better stage the disease. And at the same time, we can do some corrective surgeries as well. And she's having endometrioma as well. So endometrioma size is 5 centimeter. This size means she need IVF. And for IVF, again, 5 centimeter endometrioma we have to remove. So how we will remove this size endometrioma? There are two choices. Both are first line. One is cystectomy, and second is laparoscopic aspiration and drainage and ablation. So cystectomy associated with reduced recurrence, but more ovarian tissue loss. And ablation and drainage increase recurrence, but less ovarian tissue. So if the size is big, more than 3 centimeter size or big size, so obviously we will do more surgery, and patient will be at risk of more ovarian tissue loss. So particularly she need hair ablation and drainage, but via laparoscopy, right? And the talk article which they updated in 2025, how to do endometrioma surgeries, they said you can combine both as well. Got it? Okay. So next. So next question is that she's having a fibroid and she want to conceive. The patient is having, fibroid and they are symptomatic. So we have symptomatic fibroid in terms of pressure or in terms of HMB, we have to remove, look at the size. So the best way is to remove it. And in pregnancy and in fertility decides, myomectomy is better. Okay. So option C, myomectomy. Ablation, not a good choice if you want to preserve fertility. Embolization, not a good choice. Hysterectomy, not at all. Marina won't work more than 3 or more than 3 centimeter intramural fibroids. Okay. So a lot of flashcard from your theory course, how to actually address fibroid less than 3 centimeter, and if cavity is intact, means no submucosal fibroid, we can put Mirena. And if more, then we will refer, and they will see like she is suitable for endometrial uterine artery embolization or hysterectomies or myomectomies. At 3 centimeter, ablation is not safe, but can be considered. Okay, so more than 3 centimeter uterine artery embolization. Fertility potentially retained, but not ideal. Myomectomy is better. If no myomectomy, then uterine artery embolization we can, do. But we will discuss impact on fertility, non-targeted embolization. Common complaints are persistent general discharge and post-embolization syndrome. They love to ask both of these, and post-embolization syndrome is a late complication and more common as well. And third one is septicemia, which is more serious. More than 3 centimeter, we have options hysterectomies, and in hysterectomy, the first line option is vaginal, and second line, nice is abdominal. But where laparoscopic facilities are available, then second line will be the total laparoscopy, guided hysterectomy, right? And then third line will be abdominal. And okay, and if patient want to keep her uterus or want to keep choices to produce more kids or want for any fertility preservation option, then add more than 3 centimeter. A myomectomy is better. And if myomectomy is not there, then uterine artery embolization, ablation never, hysterectomy never, if patient want to conceive. And definitive are hysterectomies, and in that sense, definitive we can say after hysterectomy ablation as well, because you are going to permanently destroy the endometrium. Okay. Again, symptomatic fibroids and wishes to preserve fertility, and there is 8 centimeter. If you go type 3 intramural fibroid, so what you will do? Never ablation, uterine embolization. Myomectomy is better, and till 8 centimeter we can do laparoscopy as well. After 10 centimeter, they said it's not a very good option. So we can do myomectomy abdominal, hysteroscopy, and laparoscopy. And for laparoscopy, remember, 5 centimeter is ideal, 5 to 8 feasible, but with experience, 8 to 10 challenging but possible, and after 10, never do laparoscopy guided myomectomy. And here 8 centimeters, so yes, possible. Yes, possible, feasible with experience. And they have added the option of open as well. And other figure classification, remember them. What does it mean by 0 pedunculated? What does it mean by 1? What does it mean by 2? Okay. Heavy menstrual bleeding caused by multiple fibroids. She has completed her family and wishes to avoid major surgery. Major surgery means she don't want hysterectomy and myomectomy. So for HMB, for multiple fibroids, what are the options? Minimal invasive uterine artery embolization, and option is there as well. 33 nulliparous laparoscopy. She has severe endometriosis and has been scheduled for laparoscopic surgery, which intervention has the strongest evidence for reducing the recurrence of endometriosis associated with pain following the surgery. Means they want to secondary prevention. For secondary preventions, OCPs are best, and long term they can be used versus DNRH. Okay, so continuous combined HRT. And their reference is Escher and also nice. Again, they love endometriosis, they love HRT and endometriosis and HMB. I think the whole paper revolves around these three main topics. So 31 again, deep infiltrating endometriosis and involving the bowel has a persistent symptom despite medical therapy. So we will refer her. Then first line treatment for endometriosis is OCPs. We can give oral, vaginal, or transdermal, and continuous is better. And then progestogens, oral progestogens, and then GnRH agonists, then antagonists, then aromatase inhibitors. Aromatase inhibitors and GnRH both are second line, and OCPs and progestogens both are first line. Okay. So aromatase inhibitors can be given in deep endometriosis and can also be given in refractory to the other medical or surgical treatment. So remember these buzzword for aromatase inhibitors in endometriosis. 46, endometrial hyperplasia but no ETPia. So ideal first line is Marina, and she don't want surgery as well, neither needed. So option C, Marina. 52-year-old patient presents with postmenopausal bleeding. TVS demonstrate endometrial thickness of 7 mm. 7 mm is too much with PMB. More than 4 is enough for biopsy, and the ideal we have to do endometrial biopsy and with pipal. And as there is no pipal, then okay, fine, hysteroscopy as well. However, if they mentioned there are focal lesion inside the cavity, TVS suggests that thickness is irregular, then hysteroscopy is must. Here they have a plus minus, means you can or you cannot. Biopsy is must, and first line is pipal guided biopsy in postmenopausal bleeding if TBS suggests thickness is 4 or more. Okay. 31-year-old patient with PCO has oligomenorrhea and wishes to reduce her long-term risk of endometrial hyperplasia. She is not planning pregnancy. What is the most appropriate management? So option C is best, right, Myrina? Endometrial hyperplasia first line treatment is without atypia is Myrina. Persistent heavy bleeding, 45 her age, her family is complete, ultrasound is normal, biopsy is okay. She requests definitive treatment, but she don't want hysterectomy. So after hysterectomy, the definitive is ablation. And ideal as well, because biopsy says there is nothing suspicious, because this is prerequisite to do ablation. That endometrial biopsy should be done and it should be normal. 48 postcoital bleeding and cervix is suspicious, so we have to refer her for colposcopy. Okay. Option C, but urgent suspected cancer refer for colposcopy. And we have done this question as well multiple times. And if clinically abnormal cervix, you have to refer for colposcopy that patient. On fast track ground, 35-year-old patient is found to have persistent SIN3 on colposcopy following previous excisional treatment. She has completed her family. What is the most appropriate management? Only observation is not enough. However, we know that SIN3, if removed, test of cure normal, and biopsy shows positive margins only. In that case, we can actually keep her under follow-up. So here, option C is better because she is having persistent SIN, not positive margins. So positive margins after lead for excision, no biopsy proven recurrence. Then we can, keep her, under surveillance if her age is less than 50. But here they said the persistence of SIN3 on colposcopy, not positive margins, means SIN3 is there. It has not been treated adequately at all. So you have to repeat excision treatment. And her family is complete, so you can do hysterectomy as well, because hysterectomy is also excisional treatment and can be offered if family is completed under MDD. Okay, so that was tricky. 24-year-old patient, nulliparous, presents with persistent vulval itching. Examination reveals plaques involving the vulva. Punch biopsy confirm lichen sclerosis. What is the most appropriate first line? So remember, if lichen sclerosis comes, you have given treatment, and after treatment there is recurrence. Then we do biopsy, right? This is the stepwise approach. If a patient like check her age, she's nulliparous, only 24, having persistent itching, the white flags involving the vulva. So they were suspecting the vein here. For vein, they have done biopsy. Although it is rare at this age, we don't see lichen sclerosis at this age, but they confirm lichen sclerosis. So again, they confirm this is lichen sclerosis. They have not confirmed it is vein. Got it? Okay. So that's why we will give her lichen sclerosis first line treatment, which is high potent local steroid clobetasol, 0.3%. If I change the statement, confirms lichen sclerosis plus vein, then you will not treat her with only steroid. This is precursor, pre-malignant condition. You have to remove it. You have to excise it. Okay. So here we will give her treatment only, which is option C, clobetasol, 0.05 or 0.03 ointment. 67-year-old patient, vulval lichen sclerosis, developed persistent ulcer, and she has taken treatment as well. So treatment failure and now aggressive. So you have to do biopsy. Okay, punch biopsy. Like we don't do for biopsy any seasonal biopsy. We do at vulva in seasonal biopsy. It means punch biopsy is okay, fine. 36-year-old patient presents with recurrent painful Bartholin gland abscess, and 2 times drainage has been done. Basically, for Bartholin, we should do the first line treatment, which is marsupialization. If we opt insulin and drainage, it means there will be more recurrences, and here are the recurrences as well. So with marsupialization, there will be the less recurrences. You need that treatment. Okay, oral, no need. Needle aspiration, no need. Word catheter, not effective as marsupialization. Simple insulin already have tried 2 times, so marsupialization is okay fine. 57 postmenopausal persistent unilateral ovarian cyst, which is 8 centimeter with papillary projections, and look at her CA125, 500. So her straightforward her RMI is 5 more than 200. So you have to refer her, gynecology, oncology with multidisciplinary input. So, and 6 month repeat, not good. Aspiration, not good. OCP is not good. Laparoscopic cystic drainage, not good. So option C is, exclusion key. Ideally, we should calculate her total MRI and we should, do her CT. Then we have to refer her. But no ideal option, so that's why option C is okay, fine. Complex ovarian borderline tumor, 42 her age, and she want to preserve her fertility. And borderline tumor, we don't do aggressive treatment as we can give, liberty that she can preserve her fertility as well. So TH, BSO not needed, DSO not needed. Fertility sparing unilateral salpingophorectomy with staging is, ideal here because you want to preserve her fertility. And acute onset pain and the absent blood flow, this is torsion, and you have to do urgent laparoscopy for this. Question number 39, bilateral complex adnexal masses with ascites, and look at her age. So it's mean we have to check her CA125 and we have to check her RMI, and definitely her RMI will be more than 200 roughly, we can assume, with the ultrasound features. 2 features are positive ascites and bilaterality, right? So the option CT, chest, abdomen, pelvis is okay at RMI more than 200. Okay. Question number 40, 63-year-old patient undergoing primary cytoreductive surgery for advanced epithelial ovarian cancer. Which of the following is the strongest prognostic factor for overall survival? That was tricky. So yes, patient age is important, histological subtype is important, somehow non-specific role of CA125 as well, and tumor grade or histology as well. Because if high-grade tumor means, poor prognosis. But among them, the residual macroscopic disease after surgery is strongest. Remember this. Okay. Residual disease after cytoreductive surgery is the strongest surgical prognostic factor in advanced epithelial ovarian cancer. For advanced epithelial ovarian cancer, the single most important prognostic factor after primary surgery is achieving complete macroscopic cytoreduction, leaving no visible residual disease. And this principle is consistently endorsed by BTS and a lot of European guidelines, including the FIGO. And question number 41, stage 1B1, she wishes to preserve her fertility, and MRI shows 1.5 centimeter tubal with no lymph node involvement. But MRI shows, still at stage 1B1, we have to do, pelvic lymph node dissection, and she want to preserve her fertility as well. So radical trachelectomy with pelvic lymph node dissection is the ideal key. Until stage 1B1, we can offer fertility preservation as well, but not at 1B2. Okay. So last question, they ask about a new term newborn with ambiguous genitalia is found to have elevated 17-hydroxyprogesterone. Which enzyme deficiency is most common in CH? Everyone knows this is 21-hydroxylase deficiency, but remember, there are two or three more types of CH. One is with 3 beta HSD, one is with 11 beta hydrogenase, and last one is 17 alpha hydroxylase. Okay, 21 and 3 beta associated with hypotension, 11 and 17 is associated with hypertension. And because of this reason, sodium is high in both. And because 21 and 3 are associated with the hypo, so sodium is low and potassium is high. Okay. So they can test other enzymes as well. So this card will help you. So congratulations, we have done general gynecology module, and you can see 41 questions from this guide. So 41 questions are coming up from general gynecology, and 40 plus are coming up from maternal medicine, and 40 plus are coming up from labor and delivery. So if you are doing these three modules well, trust me, you are 60% more safe. So give particular importance and towards these modules. In next recording, I will cover your maternal medicine and labor together. Thank you very much. Let me know if you have any doubt. I will cover it in next session.